Welcome back to part two. So we're going to just do a high-level overview of cardiogenic shock. We've already talked about that. And then we'll look at the distributive shock, so anaphylactic, septic, and neurogenic shock. So as you recall, cardiogenic shock, the most common cause is the result of a myocardial infarction. It results from heart failure, whether systolic or diastolic, or actually dual heart failure. It has an 80% mortality rate, and it's considered the engine malfunction because the normal compensatory mechanisms lead to the ultimate heart damage. And so what do I mean by that? Well, a decreased cardiac output triggers the sympathetic nervous system to try and maintain the blood pressure and the cardiac output. But those normal homeostatic mechanisms to maintain blood pressure and the circulating volume are really counterproductive for the patient in cardiogenic shock. So it actually adds a lot more workload to the heart that's already under stress. And so what happens is that you have increased heart rate, increased contractility, stroke volume is increased because of the activation of the sympathetic nervous system, both of which can lead to increased ischemia. And if it's the myocardial infarction that's already causing this, you can see the impact that it's having on the heart. So you have water retention, which increases the workload on the heart. You have an increase in afterload, and so the heart has to pump harder to get blood out. There's an increase in demand for oxygen and nutrients from this failing heart, and it leads to this overall pump failure. And so you have this falling blood pressure, cold, clammy skin, because for one thing, the blood is shunted away from the periphery, but also because the heart is just not able to pump. You have an increase in sodium and water retention, oliguria, because the kidneys are now coming into play and they're sensing that they need to hold on to water and hold on to sodium. You could have pulmonary congestion in the form of pulmonary edema, so you may have dyspnea. Neurologically, you start to see changes, anxiety, confusion, agitation. You may have nausea and vomiting because of decreased bowel sounds, so again, shunting blood away from the abdomen. May have chest pain, arrhythmias. It's likely to see an increase. You're likely to see an increase in blood glucose because the body's under stress, so it's trying to produce more sugar to fight. Cardiac markers could be even further increased from what they already are. Maybe from after having an MI, they're already increased. They could be further increased, and you're going to have an increase in your BUN and your creatinine because of your renal system. So the collaborative care is trying to improve the oxygen delivery and increase the supply. So you need to reestablish the blood flow, and that may require surgery through bypass surgery or angioplasty if there's actually a revascularization problem. You may be giving, or you will be giving, certain types of drugs. So you may be giving drugs to dilate the coronary arteries, to get that blood flow back to the heart, to improve the contractility, to reduce the preload, so there's not enough, so blood is not coming back quickly to the heart. You want to decrease the stress on the heart, so you don't want to have a whole lot of blood coming back to the heart. So reduce the preload, make it manageable for the heart to pump. Reduce the afterload so the heart can pump out easily. Reduce the heart rate and reduce contractility. So there's a lot of drugs that come into play. You may need to control pain if the individual's having pain from the extra workload on the heart and they're having ischemia. Treatment of arrhythmias. And then the heart may need some circulatory assist. So there may be the placement of an intra-aortic balloon pump as a temporary measure to help the heart. So moving on to distributive shock, there's three types: neurogenic, anaphylactic, and septic. And it's characteristically related to vasodilation. So there's a loss of blood vessel tone, enlargement of the vascular compartment, and displacement of the vascular volume away from the heart. And so the blood volume is trying to be consistent, but what's coming back to the heart is not enough blood to pump properly because of this vasodilation. And so the heart is really working hard to get a constant blood volume out. So if we look at neurogenic shock, it is the rarest form, and it's most commonly associated with spinal cord injuries at or above T5 or a closed head injury. We also do see it with spinal anesthesia or anytime there's vasomotor center depression. So within, like as in severe pain, drugs, hypoglycemia, or injury. And what we're seeing is factors that stimulate the parasympathetic nervous system or inhibit the sympathetic nervous system. And so let's go into a little bit more pathophysiology. So what you'll see what's happening here is that when you have a disruption in the sympathetic nervous system, you'll lose that sympathetic tone. But what also happens is if you knock out the sympathetic nervous system, the parasympathetic nervous system will have a response. And one of their typical responses is decreasing the heart rate. And you'll see how this comes back into play. So if we have an insult on the neurological system, we have disruption of the sympathetic nervous system. So you lose your sympathetic tone. Sympathetic tone is responsible for vasoconstriction. So if we lose that tone, we have venous and arterial vasodilation. Your blood pressure will drop. The venous return will drop to the heart, leading to decreased stroke volume, decreased cardiac output, and on top of that, you have a decreased heart rate because of the parasympathetic nervous system response. So all of those leading to decreased oxygen supply, decreased tissue perfusion, and eventually leading to impaired cellular metabolism. So you can see that imbalance again between supply and demand. So these are the clinical manifestations. So you're going to have hypotension, bradycardia, something called picolothermia. I don't even know if I pronounced that right, but basically what it is a form of hypothermia, but the true definition is that the patient takes on the temperature of the environment, so they don't regulate their own temperature. The patient could have cool or warm dry skin, flaccid paralysis below the level of the lesion, loss of reflex activity, so your bowel and your bladder function could be impacted, and there may be an increased ICP. And so signs of an increased intracranial pressure are vomiting, headache, changes in behavior, a progressive decreased consciousness, neurologic deficits, and seizures. And so the collaborative care is all about treating the underlying cause again. You'll be responsible for careful neurologic observations, so your Glasgow Coma Scale, monitoring the temperature, watching for DVTs from blood pooling as a result of that vasodilation, watching for an increased intracranial pressure, and if it's related to spinal anesthetic, you'll reverse the anesthetic if appropriate. So let's move on to anaphylactic shock. So anaphylactic shock is acute, life-threatening hypersensitivity reaction. It causes massive vasodilation, release of mediators because you go through that inflammatory response, and increased capillary permeability. And so the systemic allergic reaction is from an antigen, but remember that this would only occur on the second exposure to the allergen. The first exposure produces the antibodies to the allergen, and then on the subsequent exposure, the allergen provokes the defense reaction. So just remember that part. And so what are you going to see? You're going to see in the cardiovascular, you may see an individual with chest pain, or there may be third spacing happening. Remember, it is this massive vasodilation again. For the pulmonary system, we tend to see a lot of swelling of the lips and tongue, shortness of breath, wheezing, edema of the larynx and the epiglottis. The skin can be flushed. You could have pruritus, urticaria, or angioedema. Neurologically, you start to see individuals with anxiety, impending doom, maybe confusion, decreased level of consciousness. And for the GI, you'll see patients with abdominal pain, cramping, nausea and vomiting, and diarrhea. So there's a lot of clinical presentation with an individual with anaphylaxis. So one of the first things that you're going to do is withdraw the antigen immediately. So if it's from, let's say, an anaphylactic reaction to a blood infusion, you would immediately stop that. If it's from a contrast dye, you would immediately stop that. You want to optimize ventilation and oxygenation, so you're right into your ABCDs. Drug therapy, really important. You're going to give epinephrine, possibly bronchodilators, antihistamines, corticosteroids to help with that inflammatory response. Most often, or I shouldn't say most often, you will be giving fluid resuscitation because of that massive vasodilation. And again, maintaining that airway, so intubation and maybe mechanical ventilation. And then after the sequelae of the septic shock is over, the education should focus on the prevention of exposure to the antigen and use of an EpiPen. Oftentimes, if the source of the reaction is not determined, then a referral to an allergist may be appropriate. And they may recommend that the patient pre-medicate themselves prior to any history of the sensitivity, such as contrast dye, for example. So the last shock I want to speak to is septic shock, and it's the most common form of distributive shock. And so if we think of the word sepsis, sepsis is systemic inflammatory response to a suspected infection or a documented infection. Severe sepsis is sepsis and organ dysfunction, hypoperfusion, or hypotension. And so this is where, when we get into severe sepsis, we're actually moving into septic shock. And so this is bacteremia, which leads to a chemical cascade and inflammatory response. And so you get this severe vasodilation, increased capillary permeability, and the most at-risk individuals are elderly, neonates, the critically ill, the malnourished, and the immunocompromised. And so most of septic shock comes from gram-negative, for examples through an invasive catheter, abdominal surgery, and also gram-positive bacteria as well. So that's typically where you see the septic shock, gram-negative and gram-positive bacteria. So septic shock is a little bit different in that it has early signs and late signs. So the early signs of septic shock are based on that massive vasodilation. So the skin is pink, warm, flushed skin, tachycardia, a bounding pulse, maybe an increased respiratory rate, decreased systemic vascular resistance because of the vasodilation, an elevated cardiac output because trying to pump out to this vasodilated state. So the heart rate tries to increase, try and get that blood out. And there may be some interaction or effects on the respiratory system. So you may notice some respiratory congestion, pulmonary edema, because of the vasodilation and this increased capillary permeability and things like that. The late stages are the opposite. So this is where the heart and the body's trying to compensate. So now we go into that vasoconstriction. Skin is pale and cool, trying to get all the blood shunted back to the heart. Tachycardia still, a drop in blood pressure, changes in level of consciousness, an increase in systemic vascular resistance because of the vasoconstriction. The heart is having a tough time pumping, so there's decreased cardiac output. There is this change in clotting dysfunction that happens as well, which is very only known to septic shock, is where you have this increased coagulation and inflammation and the formation of microthrombi and some obstruction of the microvasculature because of the changes in the clotting dysfunction, and then all leading to metabolic and respiratory acidosis. So if we look at the progression of sepsis, you start off with a bacteremia or other infection in the blood, and this leads to your SIRS. The SIRS, an individual can have an elevated temperature above 38, or maybe they're not able to regulate their temperature and it's actually below 36. The heart rate is usually tachycardic or above 90. Respiratory rate is increased. The PaCO2 is dropped because of that higher respiratory rate, and the white count tends to be high because there's an infection brewing somewhere. If we look at what sepsis is SIRS plus the infection. Severe sepsis is sepsis and end organ damage. Septic shock is severe sepsis and the refractory hypotension, so that later stages of sepsis. And then MODS is that multi-organ dysfunction syndrome, and that is usually where you see the high mortality rates. So what are you going to start to do in the first hour of identification of an individual with this SIRS criteria? Well, one of the first things is you'll be measuring a lactate level because you want to see the anaerobic metabolism have we moved from aerobic metabolism, which is normal, to anaerobic. If we see a rising in the lactate levels, we know that the demand for oxygen and the supply and demand is not compatible. Obtain blood cultures before administering antibiotics. So we want to start antibiotics right away, but we want to get those blood cultures first. You're going to administer broad spectrum antibiotics. You're going to start your fluid resuscitation, so rapid administration of crystalloids for hypotension and an elevated lactate level. You're probably going to start some drugs, so vasopressors if there's hypotension during or after the fluid resuscitation, and you're trying to keep that mean arterial pressure above 65. So your vasopressors are for your vasoconstriction, your increase your cardiac output, increase your contractility. That's what they're used for. So let's look at our collaborative care for septic shock. We absolutely want to identify the causative organism, so you're going to be doing those blood cultures, probably starting broad-based antibiotics until you actually know what the organism is. Really important for early oxygenation to increase that supply, decrease the demand, treating with appropriate antibiotics once you know what that culture is. Administer IV fluids, plus or minus inotropes to increase that sympathetic nervous system, increase the contractility. If there's an acidosis, you're going to correct that acidosis. And then you're going to be very strict with your universal infectious disease precautions. And so that patient most likely may be put on isolation because we don't know what has caused this sepsis. So the patient may be put on isolation, and you're going to be very important, strict aseptic technique with any of your IV lines, if there's a wound involved, if there's suctioning involved, because this patient is very, very sick from an overwhelming infection, and we don't want to add to that. So let's talk a little bit about the pressures. Remember, we talked about the CVP and the wedge pressure and the cardiac output and the systemic vascular resistance. So in hypovolemic shock, let's think about what's happening. We're not having enough fluid volume coming back to the heart because you have a decreased circulating blood volume or fluid volume, and so it's going to be decreased. Our PCWP is also going to be decreased because overall, in general, we have hypovolemic and a low volume. Cardiac output is going to be decreased, but our systemic vascular resistance is going to be increased because of that compensatory mechanism. So you have that vasoconstriction. In cardiogenic shock, remember we have the pump failure. And so you're going to have fluid overload. So your CVP and your PCWP are going to be increased. Your cardiac output is not going to be great. And you, again, have that vasoconstriction. So you have the systemic vascular resistance is going to be increased. Remember, in sepsis, everything's vasodilated. And so the fluid coming back into the heart is going to be decreased. So your CVP and your PCWP is going to be decreased. Your cardiac output is going to be increased because you go into that hyperdynamic state. But remember the vasodilation, the systemic vascular resistance is going to be decreased. So the key points, the most important factor is prevention. So identifying patients at risk for shock, surveillance, and early identification of shock. And so shock leads to a mean arterial blood pressure that's inadequate to meet the demands of the tissues. Early symptoms of shock may be subtle. You may not recognize them. All clients are at risk of deterioration, require collaborative care. You need to have a good understanding of the pathophysiology of the different types of shocks, and psychological support is really important because it can be a very frightening experience for the individual. So let's move on to Hospital Code Blue and your role as a nurse. So your role is to observe, Really important to provide space for the team to do what they need to do and assist as directed. So you're going to stand at the back of the room. You will never ever push IV medications, even when asked, because that's out of your scope of practice. You need to understand the process, but as an individual, you don't have an active role. You're going to be more just stepping back. And to have an active role requires advanced training, and you will get that training when you get your first RN job. But let's go through an adult cardiac arrest algorithm. So a code blue is called. You're going to begin CPR, administer oxygen, attach the defibrillator and the monitor. What is the monitor telling you? Is it a shockable rhythm is the first thing. If it is, yes, those are only two shockable rhythms, VFib, ventricular fibrillation, or pulseless VTAC. If you've got one of those rhythms, you are going to shock the patient. Going to continue CPR for 2 more minutes. Make sure you have IV access. If you can't get it into the vein, you may have to get it into the intraos. Not you, but an anesthetist. But you want IV access. Again, look at your rhythm. Is a shockable rhythm? Yes, you shock the patient. You continue CPR for 2 more minutes. At this point, you're going to start giving the drugs. Epinephrine is going to be your first line drug. At this point, you're going to consider advanced airway, what's happening. And capnography is just looking at a quick indicator of the arterial blood gas. Again, you're looking at the rhythm. Is it a shockable rhythm? Yes, you're going to shock the patient. 2 more minutes of CPR, and then you're going to start giving your other antidysrhythmic drugs. And this is going to keep going around and around and around. Up here, if you look at your rhythm and you see it's not a shockable rhythm anymore, you're going to come down to here. And then you're going to look at this return of spontaneous circulation. So if there's signs of return of spontaneous circulation, then this patient you'll get this patient ready to be transferred to the post-cardiac arrest care unit, whatever that is. If no signs of return to spontaneous circulation, you go back up and you start going through your steps again. So let's go up here. And what if you look at your rhythm and it's not shockable? So you go over to here. Okay, so is it an asystole or a pulseless rhythm that we can't really tell what it is? And you haven't learned that rhythm, so I'm not going to go into detail about that rhythm. But what if it's asystole? Well, you'll still do CPR for 2 minutes and give epinephrine. Make sure you have your IV access. Consider advanced airway. Whoops. Is it a shockable rhythm again? If it's no, CPR for 2 minutes. You're going to treat any reversible causes. But if it is a shockable rhythm, you're going to shock it, and then you're going to follow this algorithm over here. So treat the reversible causes. Look again at the rhythm, yes or no. And so if it's a shockable rhythm, you're going to shock it and go through the other side. If it is not a shockable rhythm and return of spontaneous circulation, then you're going to follow this sign here. If either one of them, if you're not getting anywhere, then it will be time for whoever's running the code to decide whether they're going to continue to run the code, continue with CPR, continue giving the medications, or whether they're going to stop, because this patient is probably not going to come back from their cardiac arrest. And so documentation, should I document? And so what I would say is I would be the individual that would step back. I don't think you're qualified as a nursing student role to do the documentation. So I would take a step back and say, no, I'm not qualified to do that, because you haven't been trained in documentation in a code situation. You don't know what the flow sheet looks like. So I would say no, that you're not allowed to do that, but be able to provide assistance in your role as a student nurse as any way you can. Maybe it will be if the family are at the bedside with the patient, it's maybe escorting that family member out, or family members into the waiting room and staying with them. And so you will just ask in what way you can help in that situation.